So good evening. I would like to welcome everyone today to the first webinar for 2022 and remind everyone to please remain muted at all times. Now, the Circle of Health program of Rambam, and there's a special website now for our Circle of Health. Just type Circle of Health and Rambam into your browser and you'll find it. This program advocates for improved health and well-being in our community through disease prevention, positive lifestyle changes, and education. Now, this is achieved by conducting a variety of health and wellness educational programs using local expertise and strengthening global collaboration with world-renowned facilities, particularly those affiliated with the Rambam Health Care Campus in Israel. This program also facilitates flagships research collaboration between the Rambam Healthcare Campus and Australian medical research institutions. Now, the Rambam Healthcare Campus is a 1,000-bed world-class teaching hospital based in Haifa. The patient population is diverse, as Rambam is the major referral medical centre for all of northern Israel, serving more than 2 million residents and others referred from all over Israel, the Mediterranean region, and around the world. Rambam is respected internationally for its clinical services, innovation, and medical technology. This webinar is an event linked to the Rambam Ride, which is happening next Sunday, February the 27th. And for the fourth year in a row, Maccabi Cycling Victoria and Australian Friends of Rambam have joined forces to improve community health and raise awareness of sudden heart failure. The money raised from these events goes towards ongoing heart health awareness activities. So please join the ride next Sunday, February the 27th. You can type in My Cause, MYCAUSE, and Rambam Ride 4, and you'll be able to find the website quite easily. Now, from tonight, I'd like to thank first our guest speakers, the Israeli Embassy in Australia, that is, Zionism Victoria, Maccabi Victoria Cycling Club, and their president, John Gould, Shlomo Immerman Partners, Gary Peer, Zohar Edelstein Jewelry, Pista Bikes, Baker Heart and Diabetes Institute, and to the Rambam Health Care Campus for all supporting the efforts of the Rambam Ride. And I'd like to invite in a moment Dr. Edna Schiffman to introduce our speakers. Edna is an Australian serial tech startup founder, investor, and executive chairman of global athlete analytics leader Catapult Sports. He has been rated the world's 10th most innovative person in sports business. I hand it over to you, Edna.
Thanks, David, and welcome everyone to another fantastic webinar. We're very lucky to have really two of the most esteemed people in the field of cardiology on this webinar. It's going to be a very fascinating conversation. Some of the endeavors in which each of them is involved is unbelievably innovative and overwhelmingly sophisticated, and we'll talk about it in very understandable and approachable terms. And I think this will be very much an enjoyable next hour for everyone. So let me first just give some brief background about our two guests, our two professors. So Professor Tom Marwick is the director and CEO of the Baker Heart and Diabetes Institute. He's a foundational member of the Australian Academy of Health and Medical Sciences, a recipient of personal awards and honours, including the Eccles Award of the National Health and Medical Research Council of Australia, an associate editor of the Journal of the American College of Cardiology, deputy editor of that journal, the Cardiovascular Imaging, and former chair of the Heart Foundation's National Research Committee. And I will add, one of the most distinguished and esteemed and awarded medical professionals in Australia. And he doesn't have to respond to that. He can be modest, but that is a fact. So welcome, Tom.
Thank you.
And we also are lucky to have from Israel, Professor Lior Gepstein, who is the director of the cardiology department at Rambam Health Care Campus. Lior graduated from the Rappaport Faculty of Medicine at the Technion, Israel Institute of Technology, and conducted his PhD studies at the same institute. He completed his internship and residency in internal medicine, as well as a cardiology fellowship at the Rambam Health Care Campus, This was followed by a 2-year fellowship in cardiac electrophysiology at the University of California, San Francisco. Currently, he holds the position of Professor of Physiology and Medicine, Cardiology at the Technion's Faculty of Medicine, and holds the Edna and Jonathan Sohnis Chair in Tissue Engineering and Regenerative Medicine, in case you thought we weren't going to be smart enough tonight in this conversation. He also serves as an attending electrophysiology specialist at Rambam. Of course he does. Welcome, Lior. Well, so that was the first 5 minutes of getting through your credentials, which are both overwhelmingly impressive. But I might start with kind of a non-medical question to begin with, in some senses, to both of you. But Lior, you know, we know that Israel is really at the cutting edge of medical research in a lot of ways. The Technion, 50 years ago was an early pioneer in the field of stem cells. You've spent time in Israel, but also overseas in San Francisco. You've won American awards, you've won European awards. It would be interesting to get a feel for, as an Israeli traveling around the world, what is, your experience of the perception of Israeli sophistication around medical research relative to your peers in other countries?
Thank you, Adir, for the introduction and for the question. So one of I think something that we are very strong in, and this relates to the success Israel had as a high-tech community, startup nation, is that we've been very, very strong in development of medical devices historically. So some of the first technologies that are currently used in cardiology, that transformed in cardiology, started here. For example, the CEO of our hospital, the former CEO of our hospital, was the developer of the second stent, the coronary stents that we put in coronary arteries in order to open occluded arteries. He later was also a founder of a company that does robotic catheterization, which was recently sold for $1 billion to Siemens, which will allow cardiologists to do the catheterization with a joystick from their home, theoretically. So these are, for example, 2 innovations in the field of interventional cardiology that actually started here. I was, as a young PhD student, involved in the development of a mapping system of the heart to treat cardiac arrhythmias. It's called the CARTO system, and it transformed the way we treat arrhythmias because it allows us to, like a small GPS in a catheter, to perform 3D construction of the heart chamber to induce the abnormal rhythm disorder, and then to identify its source and ablate it. And it really changed the way we treat arrhythmias today. I think hundreds of thousands and maybe millions of patients are treated yearly with this device. So this is another transformation that started from here, from the Rambam and Technion. So we've been very, very good in developing medical devices and changing paradigms in treatment. But I think the next frontier, and maybe we'll talk about it later, is maybe we don't have to implant devices or use devices. Maybe we can use biology to treat the heart. So if the heart suffers damage and heart tissue is lost, maybe we can just replace it with new heart cells. And this is the next breakthrough that we may be talking in the next few minutes.
Absolutely.
How to use stem cells to repair the heart.
Well, we will
this
talk
also
about
started here in Rambam.
Well, your work on stem cells is fascinating. We'll talk extensively about that, as well as, pacing of the heart using optical frequencies. So we'll get to all of that. But, my summary of what you said is people kind of get that Israel is very sophisticated in tech and medical research. And, Tom, you've been like in many places around the world. You've obviously in the US, you've been to Belgium, time in Queensland, Harvard. You've even been to the innovation capital of the universe at Hobart. And, you're the head of cardiology at the Cleveland Clinic, which is a tremendously esteemed organization. Now you're back in Melbourne. How do you find Melbourne in general, the Baker more specifically, compares to some of the experiences that you've had overseas?
Oh, well, first of all, Adir, thanks for the invitation. Thanks for the kind introduction. Look, I think Australian cardiology is very strong in application and translation. And I think the Baker has a very strong history of that. I'm very proud of being involved at the Baker. It was the institute that put the importance of the autonomic system in heart failure on the map. In fact, going back to the late 40s, early 50s, it was the place actually where the type 1 and type 2 diabetes were first distinguished. So it has a long history of innovation, but I think in contrast to some of the things that Lior has commented on, we are not so good in Australia at commercialization. We don't have the ecosystem that the Israelis have. I think we're very, very good at adoption and at clinical trials and understanding incremental value and things along those lines.
Oh, that's very interesting. Well, you know, I'm gonna stay with you, Tom. And before we talk about treatments, it's worth speaking about the diagnosis of various cardiac conditions, because that's been a big area of focus for you, you know, and in particular heart failure. And, you know, just to explain it in the simplest terms, really with heart failure, we're talking about the failure of the heart as a pump to be able to function effectively from a whole variety of different causes. And the first question I want to ask you is a pretty simple one, which is, like, why is early diagnosis even important in that condition? Explain, like, why early diagnosis of heart failure is actually important.
Yeah, no, it's a really important question. So heart failure is a common condition for people living in Western countries. The lifetime risk of developing heart failure is between 20 and 25%. The issue at the moment is that heart failure is being diagnosed late. And by the time it's diagnosed, a lot of the changes are very difficult to overcome. And so a lot of effort has been devoted towards earlier diagnosis, because we figure that if we can interrupt the process before the heart scars, then that is something that could be reversible. And so a lot of effort has been put into understanding the so-called subclinical phases. And you can think of heart failure as a spectrum going from the risk factors for heart failure all the way to somebody being so sick that they need to come into the emergency room. And in the course of that, there is a phase before people have any symptoms that their heart is sick, and discernibly so on imaging tests in particular. And so that's been our focus, to try and identify those folk and treat them before they get into trouble.
And at the moment, you know, when you're thinking about heart failure, what, you know, giving people some perspective at the moment as to kind of the gold standards for as early as we can diagnose heart failure at the moment. People in this webinar will have had experience with some of these. What are the type of modalities at the moment that are mostly used? Yeah, so the one that, so I think in general, there are two major strategies. One is called biomarkers or blood tests, and the other is imaging tests. The difficulty with the biomarkers is that they're not very specific. There's other things that can interfere with them. And so we haven't found them very satisfactory for this purpose. From an imaging standpoint, the one that is most widely used is echocardiography or cardiac ultrasound. It is widely available, it's inexpensive, it's completely non-invasive, it's completely harmless. And so we put a lot of effort into trying to measure the deformation of the heart muscle on this test, and currently we're putting effort into trying to automate as many aspects of this as we can, so as to you might say democratize it, put it in the hands of everybody. And this extends to, for example, using robotic efforts to drive the ultrasound probe. We have a facility in Alice Springs, and we know there's a huge burden of disease in the Aboriginal community. So a lot of we have effort there into trying to solve that problem. And then we also have effort in trying to make the technique useful in the hands of a non-expert. So there's a lot of things to do. It's a very attractive technique because it is so versatile and inexpensive. And so when someone, is comes in and gets an echo, which many people will have had experience with, which kind of feels like an ultrasound and gives them a look at the functional performance of the heart effectively. Yep. They've already gone and seen at least a GP before they've gone in. And I wonder whether you think, the age that we're in now with lots of wearable technology and the quantified self, how much do you think things like Apple Watches and apps might be used to identify earlier people that have some risk factors or should be going and seeing their doctor? Yeah, look, I think it is going to have an important impact, but
you know, some of the things that we would want to measure from a complete cardiovascular evaluation standpoint, such as, for example, blood pressure, at the moment have really proven problematic with those things. So Apple Watch, I think, very interesting for looking at heart rhythm and looking at heart rate, measuring exercise functional capacity. I think that's really important because some people, you know, think that they're doing more activity than they actually are, and you can gather objective information and then that can be used to guide people. So all of those things in wearables, very attractive and potentially transformational. But from the standpoint of identifying serious cardiac disease, I think we're not quite there yet. I think there's another level of sophistication we need to get to go where we want.
Do you think we might see the increasing use of watches, apps, etc., for screening, community-wide screening of cardiac disease?
Yeah, I think we have a problem at the moment in that if you look at the mortality impact of cardiovascular research over the last 4 or 5 decades, huge impact in people in their 50s, 60s, 70s, and 80s, almost no impact in people in their 40s, simply because the screening process doesn't begin until middle age. And things that could be gathered in younger folks, such as, for example, functional capacity and so on, could be very helpful from that standpoint. And we have some longitudinal studies of people that we've followed from the age of 7 across Australia, where we're finding that those observations done in early adulthood are very predictive of what happens to people subsequently. So yeah, it could give us a means of screening that at the moment we haven't opened that door even.
I mean, that's very fascinating. And so we're going to go from all the way zoomed out to the community level to zoomed right into the cellular level in a moment. But I should add that if you do have a question that you want to ask, just drop it in I think there's a chat section, because this is a meeting rather than a webinar. So just drop your question in the chat section and I'll get to it and I'll try and incorporate it into the conversation. Lior, we're going to zoom in now. I know the work that you are doing on genetic approaches and stem cells, pluripotent stem cell approaches to cardiac disease is remarkable. Tom spoke about the problem. One of the problems with heart disease is that once that cardiac muscle is damaged, it's not readily replaced and you end up with scar tissue. The work you're doing is incredible. Tell us a little bit about the work you're doing with stem cells that potentially could have an effect in that kind of situation.
Yeah, so Thomas was correctly referring to heart failure, as an epidemic, and it's just to understand it's responsible in some areas for more hospitalization than all forms of cancer combined. So heart failure is a huge problem everywhere in the world. Although we have much better treatment than we used to have before, we still don't have an ultimate solution to replace areas that are not functioning well in the heart, beyond replacing the entire heart with a new heart. So many years ago, people thought, why not, instead of replacing the entire heart, why don't we just replace the area that is not contracting well with new heart cells? The problem is, since the heart cannot regenerate, where do we get these heart cells? And interestingly enough, both Israel and Australia were pioneers in the field of embryonic stem cells. So these pluripotent stem cells, embryonic stem cells that made a lot of noise 20 years ago, the first 2 embryonic stem cells were generated were, one, a collaboration between Israel and the US from Rambam, and second, a collaboration from another Israeli guy from Hadassah with Australia. And these embryonic stem cells are stem cells that are very early, and they have the capacity to become any cell type in the body, in the lab, in the culture dish. And we learned over the years how to push them to become heart cells and not liver cells and not bone cells and so on. So now we can make more than 1 billion heart cells that we think are needed to replace damage in one heart with something like $1,000. And there's evidence that we could repair the damage in animal hearts. So we hope that in the next 3 to 4 years, clinical trials will start in which we can use heart cells developed in the lab to replace the damaged tissue in order to help heart failure patients.
Which, I mean, you know, which is a tremendously exciting opportunity, because at the moment, you know, as we were discussing, once there's damage to cardiac tissue, to heart muscle, that's, with not much exception, that's pretty much it. You've got scar tissue there, and that leads to all sorts of problems and increases the likelihood of future cardiac events. But I think there are a few, you know, particularly fascinating things about what you've said, Lior, other than the whole thing is unbelievably fascinating. One is that you spoke a little bit about pluripotent stem cells in the past, which I think will blow people's mind. Do you want to talk about, you know, what pluripotent stem cells are? And, you know, sometimes you don't have access to embryonic stem cells.
Yeah. So the first, pluripotent stem cells is a term that means that a cell can become any cell type in the body. We don't have such cell in our adult body. You know, stem cells in our body are restricted to what they become. In the bone marrow, they derive blood cells. In the skin, they derive skin cells. But a cell that can become any other cell type in the body, the last time we had such cell was when we were a fertilized egg. So in order to generate a true pluripotent stem cells, we have to get back to the earliest cell in the embryo. Embryonic stem cells were one way to do it. They were derived from in vitro fertilization. But an even more amazing breakthrough was with the Nobel Prize winner Shinya Yamanaka work, who was able to show us that we can take an adult cell from each one of us, a blood cell or a skin cell, and reprogram it back in a time tunnel to become like a fertilized egg. So now you can take skin or blood from a patient, from an individual, reprogram the cells to become pluripotent stem cells, and then you can make in the lab his heart cells, his liver cells, his bone cells, his neurons, so they can be used effectively in the future for maybe replacement therapy. And this will be individualized to the patient, so we won't have a problem of immune rejection when we transplant these cells back to the same patient.
So effectively, you know, we might, well, hopefully we'll be at a place at some point in the future where each of us becomes the source of our own spare parts effectively by taking one of these cells, turning it back into a pluripotent stem cell and differentiating it into whatever particular type of cell, cardiac cell or whatever else it is that we might need. So I will go, I'm going to go and keep talking about this, but first I'm going to take a question from a member of the audience. Either one of you feel free to have a shot, but I'll phrase the question like this. There was a man who received a pig heart transplant not long ago. Do we know how that's going and how he might be feeling right now?
The last I checked, he was still alive, but maybe Thomas knows anything else. This has been a long-term object. Like we've been working 2 decades on these pluripotent stem cells. There have been companies that are working for more than 20 years on generating pigs that their organs can be used for transplantation. The major problems were 2, usually. One is that organ transplantation from animals create a more intense immune rejection called hyperacute immune rejection than organ from patients to patients, from humans to humans, because of some antigens that they have on their blood cells, on their blood vessel cells, on endothelial cells. And the second, that people were really afraid that there will be infections coming from the animals to humans, something like the AIDS epidemic. So these were 2 concerns that limited this. The big advancements were that the technology allows now to generate genetically modified pigs. In the specific pig used for transplantation of the heart, for example, they replaced 4 of the pig genes and introduced 6 new human genes into the pig. So some of the genes of the pigs are now human. And this, for example, allow it to be less immunogenic. So there's less rejection. And together with improvements in drugs that suppress the immune system, this allowed to overcome some of the problems that I discussed about rejection. They also grow these pigs in, facilities which are very clean for a few generations, so the risk of infection is low. But again, this was a big move forward, and we'll see how it goes.
Absolutely. Tom, do you have anything to add to that?
Yeah, I don't have an update on him personally, but I think it's still true to say that really with transplantation, you're swapping one disease for another. There is clearly a place for transplantation, no question of it. But really we need to have something more satisfactory than that. And I think, we're talking about the stage of diagnosis of disease. Well, if we were able to identify disease earlier, we wouldn't get to that sort of end stage disease that provokes those kind of major things. And remember, as Lior was saying, this is a population health problem. You can't do a heart transplant on 20% of the population who develop heart failure. So, for sure, I don't want to belittle it. It's a huge effort and a wonderful piece of science, but fundamentally, we need to have a solution for early stage disease at population level.
Yeah, well, absolutely. Well, we'll talk a bit later on about whether there might be a way to have a heart transplant for lots more of the population without using animals, which we all will have some thoughts on. But I will say as well, the early 2020s is not the time to be talking about diseases jumping from animals to human beings.
Absolutely.
It's not a popular topic of conversation.
No.
So that's definitely one of the challenges. I mean, so Tom, just, picking up on what you just said about diagnosis, one of the things I love about this conversation is it's such a innovative, high-tech conversation in a lot of ways, medtech, and now I'm going to talk about artificial intelligence. You had some involvement and were on a paper that spoke about the use of artificial intelligence and more specifically machine learning for the use in various cardiac diagnostic imaging techniques. This, not long ago, this would be science fiction type stuff. I mean, This whole conversation 10 years ago is science fiction stuff. Stem cells and all sorts of things. What are you hoping might be achievable with artificial intelligence and machine learning in the diagnostic space? What are you hoping for in that kind of area?
Yeah, look, I think that there's several aspects to this. I think the one that is kind of the lowest hanging fruit is about diagnosis. At the moment, if you have an imaging test of some sort, a human looks at it in the midst of interpreting a whole heap of other studies. And it's conceivable that things are missed or misinterpreted, or the person who's seeing it doesn't have the experience to recognize something as being what it truly is. After a computer has been taught from millions of echocardiograms or CT scans or MRIs, the likelihood of that is very much less. So I don't think that machine learning will take over from the human in interpretation, but a human using machine learning will do a much better job than one not using machine learning. So the lowest hanging fruit is as an assistance to diagnosis. And then, as I mentioned before, in terms of actual acquisition of images, at the moment we do this with MRI and CT. Somebody goes into the scanner and they have a pre-programmed series of shots. It's possible to do that with all imaging modalities, and actually to modify that according to the exact question that's being answered, that's been asked. So I see machine learning as being helpful in many ways here, and not as a replacement. I think people are, when you say the term, people are afraid that it's going to be something that is going to displace humans or dehumanize the process. On the contrary, I think it's going to take some of the humdrum and some of the routine that can easily be messed up by somebody who's fatigued or overloaded or distracted, take that out of the equation. So I'm very excited about it. I think it's going to be very important.
I mean, one of the most interesting things going on in the world today is the way that, artificial intelligence, machine learning, you can call it computer vision, you can call it convoluted neural networks, the way that is impacting all aspects of life. Medically, I know that Colin Goldschmidt at Sonic just made an acquisition of an AI business because it's really taking off in pathology diagnosis. But also, if you watch the tennis, I mean, Hawkeye is built on the same type of neural networks that we're talking about here. So it's very dramatic. What do you think it's best at, and what do you think it's not so good at, this type of AI in diagnosis?
I think at the moment it's best for the sort of categorical thing that you're talking about with Hawkeye. Something's there or it's not there, or it's able to discern a pattern that would require somebody very experienced to identify. I think the whole aspect about integrating different things to make a medical decision is very much a human skill at the moment. Now, maybe it won't always be the case, but, you know, for example, in some of the decisions we've spoken about today, cardiac interventions, cardiac transplantation, all of those things are driven not just by pathology and by science, but from talking to the patient, understanding the priorities. It's that kind of empathy that's obviously still needs a human connection. So, but you know, this has a long way to run, and I think it's going to be very, very impactful.
I mean, for what it's worth, my comment about the displacement of humans is, you know, it comes back to the complete lack of tolerance that human beings have for machines making mistakes compared to humans. So, you know, a self-driving car that has an accident and kills someone is horrific, and that we should ban self-driving cars, but everyday humans are making mistakes and killing humans all the time. So I think that, you know, handing over trust for diagnosis entirely to machines is maybe beyond the human psychology at this point in time, and maybe it always will be. Lior, you know, have you had much experience in this type of area with this type of AI technology? Is that something that you look at as well?
Yeah, so we are affiliated, Rambam Hospital is affiliated with a technological university, the Technion, which is like the Israeli MIT of the US, you know. So it's one of the leading engineering universities in the world. And so now we are developing an AI center between Rambam, the hospital, and the Technion University. And there are a lot of aspects to it. Thomas mentioned some of it. Others relate to maybe decision support systems, in which the program aids in the decisions made by physician, never, you know, instead of a physician. One of the things we did notice is that these programs, you really need to validate them. So an AI or machine learning algorithms developed in one center may be unique to, you know, specific parameters in that centers. But if you try it in another center in another country, you may not have the same results. So I think one of the things that needs to be done is validation and collaboration programs in which to see whether AI in a certain setting works also in a different settings. And I think this is an important part to develop this type of collaborations.
That's right. Well, you know, that type of machine learning is only as good as its training data. Yep. And so absolutely, we're starting to see challenges with regards to ethnic diversity, for example, amongst patient groups. So I think, you know, these are the unexpected challenges. And then there's, you know, the real unknown unknowns that are still out there, which make it interesting. Now, I'm going to come back to some tech stuff in a moment, but we've got a question now, so which is going to take me to virtually a grand round that I'm going to ask you, which is, you know, someone asked about, you know, a young patient who is at risk of developing cardiac problems. I'm going to add, maybe they've got a history of coronary artery disease. Let's say they're 30 years old. What types of things should they be thinking about to minimize their risk, or at least delay the onset of, you know, potential cardiovascular disease?
So I'll start off with that. I think at the moment, many of those people are coming to our attention because they have a family history, not because they have a personal history, but because they have a family history. So a typical story will be somebody saying, you know, I'm 40, my father died when he was 48. You know, what can I do to stop going down the same pathway? And I think the first thing is about personalizing the diagnosis. At the moment, the way we evaluate risk is based on an epidemiologic assessment from Framingham and other places that is half a century old. And it's great for telling people that they belong to a cohort at a particular level of risk, but the patient on the other side of the table from me is like, well, what about me? You know, what's my risk? And now we have tools for doing that. So for example, in somebody of the age of 40, we might do a coronary calcium score. In a younger patient, we might use a polygenic risk score to understand their genetic risk. So we would have things on top of their risk factors to decide their level of risk. And then really the treatment, what you say, you know, your question, what can be done? It depends on the level of risk. Because of course, no treatment is risk-free. So you want to you want to line up the disadvantages of the treatment with the benefit. And in a patient such as that, we now have, you know, for example, if it's premature coronary disease, we have very effective medications for controlling cholesterol, not just the statins, but also PCSK9 inhibitors and various other drugs in preparation. So I think that the key to that is really personalizing that risk for that individual, not that they feel that they're at a heightened level at risk, but specifically what is their risk and where are they at the moment? And it comes into the conversation we had before about subclinical disease. Before people develop symptoms, they have signs of early disease, and that's what these tests are showing us.
And, you know, just to provide context to the viewers, you know, when you talk about relying on epidemiological data and Framingham, like to give people some perspective, I mean, my recollection is that was basically a longitudinal study started in a US town in the late 40s, maybe, with a few thousand people. It was a specifically cardiovascular study, is that right? And lots of current epidemiological data is still based on that small cohort that started 70 years ago.
Yeah, and I mean, there are others. It's not the only one, but fundamentally, you know, I think it's given us the building blocks of understanding risk. You know, it's taught us about, for example, the risk of high cholesterol, blood pressure, etc. But I think we have much sharper tools now in personalizing risk and understanding each individual's risk in a way that we haven't had before.
And Lior, what are you telling this 30-year-old with a family history of cardiac disease and concerns about, you know, how they should be living their life or what they should be doing to reduce their long-term risk of cardiac disease?
So a couple of things. First of all, Thomas is right to mention that the tools we have today, both for treating and decreasing the risk for heart disease, is much, much better than we used to have. That's why, for example, cardiovascular mortality used to be, you know, above mortality from cancer, and now we are, at least in Israel, I think also in Australia, much less than oncology, because we've been doing a good job, relatively good job, in, you know, offering very good risk modifying drugs such as reducing cholesterol, blood pressure, and so on. And I think if you talk more and more, for example, in the area of cholesterol, people are talking on starting affecting it already when you're young, also already when you're a child, because there's a risk that builds on your history in terms of. So more and more, when you're a family, looking at family from a very young age and trying to modify the risk factors from a very young age. I think that will be something that will move forward. And also as there are also more and more imaging tools that can help us to identify disease, whatever it is, early, and then you can modify it earlier, such as heart failure, such as early coronary artery disease. In electrophysiology, we're not there yet. You would really want to know who will develop a lethal arrhythmia before. Our way of identifying that is not still that great, but we've also developed over the year things to prevent sudden cardiac death, like defibrillators and so on. But in all areas of cardiology, whether it is coronary artery disease, heart failure, and electrical problems, identifying risk early is key, and modifying the risk.
Mm-hmm. Yeah, absolutely, absolutely. And so, you know, Lior, you talked about, you actually compared cardiac disease with cancer-based disease, but in fact, there is a connection between those two things as well, because, you know, there are oncological treatments that certainly seem to damage the heart. It seems like we're not great at predicting that yet. I know, Tom, you've done some work around this. You know, tell us where we're at with that and how a cancer patient that is going through oncology should be thinking about their heart health.
Yeah, I think this is a very important area of research, and I think will be of practice as well. I think there's been an awareness that some cancer treatments, particularly the anthracyclines that are used, for example, for breast cancer and for various types of lymphoma, have got particular cardiac problems. But fundamentally, cancer patients have common risk factors to heart disease. So smoking, obesity, lifestyle features are common to both illnesses. And so that's an important driver as well as the treatment. So this goes back to the early diagnosis aspect I was mentioning before. So we have been looking at these markers of heart muscle deformation, which we can measure non-invasively as a clue to early heart muscle damage. And then in those people that are showing that signal, giving them protective medication to stop that from progressing. I think that's a much more targeted and much more attractive means than trying to give everybody protective medication, because 80% of people don't need it. Most of that work has focused on the time of chemotherapy, but one thing we're increasingly aware of is that people that were treated for cancer 10, 15, 20 years ago have now got a propensity for developing a cardiac disease. And it's what we call the multiple hit hypothesis. So some damage was done by the cancer treatment, and then on top of that, somebody's developed type 2 diabetes or they become overweight. And these insults to the heart muscle eventually become, the last straw. And at the moment, one of my research studies is focused on people 10 years post-cancer diagnosis to try and understand the frequency of this problem and to see whether, in fact, we ought to have a process of cardiac screening after cancer treatment. I think for some cancers, we probably should have that.
And so, to take that to the extreme, do you think right now, a woman that's been diagnosed with breast cancer and is going through oncology, does she have a cardiologist involved and or should she have one involved, in your opinion?
Look, I think it depends on the exact setup and her individual level of risk. We know that there are various risk factors for cardiac impairment. In the US and overseas generally, this topic of cardio-oncology has become important. Where I used to work at the Cleveland Clinic, we set up a cardio-oncology service as a referral source for giving advice about this. There are a few people in Australia trained in cardio-oncology, and places like the Peter Mac in Melbourne have got people skilled in that particular topic. I think that obviously is desirable, but on top of that, there's an issue of awareness. That, the thing that worries me most of all is older individuals suffering some reduction of functional capacity and just saying, oh, look, I'm a year older, no wonder I can't get up the stairs without feeling short of breath. And so it's that kind of presentation that we need to distinguish, is there a cardiac problem going on here? And that is, that's an education process for people who've had cancer and for their GPs.
As a conversation I was having with my teenage son recently, he said to me, someone had passed away in their 90s and he said they died of old age. And I said, well, in medicine, we don't say died of old age. Maybe we say died of multi-system failure or organ failure or whatever it is. But people that are having symptoms shouldn't just write them off as the aging process. They should go to a doctor and have them checked out. And
absolutely,
I think that's an important message. Now, Lior, I'm going to go back to the very, very, very high tech and let you brag about electrophysiology, which is not a common thing that people get to brag about, frankly, in webinars, but you're going to get to brag about this and your research into potentially one day getting rid of pacemakers for people where there has been the pacing cells of the heart have been damaged and can no longer pace. So instead of having a pacemaker, you've got, I would say, an almost magical approach that one day might be a replacement for that. Can you tell us about that?
So we are actually working on two different programs and potential solution to maybe one day replace an electronic pacemaker that we're implanting. As you said, when we age, our electrical conduction system of the heart ages, and this may result in failure of the pacemaking or conduction activity of the heart, resulting in a slow heart rate and necessitating the implantation of an electronic pacemaker. And one aspect we said, like in heart failure, where we want to replace the ventricular muscle with new ventricular cells, maybe we can replace the non-functioning pacemaker cells with new pacemaker cells. So in this specific project, we've been taking our stem cells, our pluripotent stem cells, and we learned not only what are the cues that tells the stem cells, let's become a heart cell, but let's become a specific heart cell. So now we want to, now we already know how to direct the cell to become an atrial cell, the upper chamber of the heart, a ventricular cell, the lower chamber of the heart. But now we can also know how to make it to become a pacemaker cell, what we call an SA node cell. So we did a study showing that we can now make patient-specific SA node cells. And interestingly, you can take a blood cell from a 90-year individual and make a pacemaker cell that is very similar to the day that he was born. So it's young and healthy again. And we've been showing that you can transplant it in an animal model of slow heart rate, and it can act as a biological pacemaker, starting to pace the animals. So maybe in the future, instead of putting devices like electronic pacemaker, we just regenerate your conduction system. So this is one approach that we've been taking. A second approach is another biological method that we've been using called optogenetics. This comes from algae. It turns out that algae move away or toward light because they have a protein called an ion channel, which is light sensitive. So according to light, algae knows where to move. So scientists actually cloned this protein, and they did in several animal models, put this protein by genetic engineering in the brain. And by shining light, they can now control brain activity. This is actually transformed neuroscience. This is how neuroscientists now study which areas of the brain control what. So we want to take the same concept and put, by genetic engineering, these algae proteins in the heart, so we can control the heart electrical activity by light. So you can generate a light-induced pacemaker, or even a light-induced defibrillator. So we've shown that you can stop a fast and irregular activity such as ventricular fibrillation or atrial fibrillation with light. And in contrast to the defibrillators that we use now that give an electrical shocks that are painful, this does not infect nerve endings and therefore will not cause any pain. So maybe the future to control the abnormal rhythm will be to have algae proteins in human hearts and to control the heart activity with light.
And, you know, there's an absolutely incredible video, Lior, that you have on YouTube, which maybe I'll see if Vered can send around to participants after this. It's 5 minutes long, and it's a video. I want to send it to every startup founder I know that thinks they're doing tech. I'm going to make fun of them a bit when they create a better checkout process or another filter for a photo. And I'm going to say, if you want to know what deep tech is, watch this 5-minute video and go and do something useful with your life. But that video with the blue light flashing and the heart responding is one of the most incredible things I've seen for a long time. And I suppose, you know, for people on this webinar who are not doctors, one of the kind of trickier things I think to get your head around is the heart is like an electrically powered blood pump. And a lot of our conversation has been about heart failure, which is mostly the pump not being able to pump the liquid out effectively. But what you're talking about is sometimes the actual electrical conduction part breaks and you need a pacemaker or a variety of other treatments. And, you know, there's two different sides to the coin, and probably it's a 12-sided dice, right? But there's different sides to the way the heart works, and there's that complexity. And, you know, I think that this is actually really wonderful stuff. And Lior, I'm going to, since we're on this super high-tech stuff, you know, I'm going to go even one step deeper and give people even more hope for the future. So you've spoken a lot about genetics and what you're doing with cells. And at the moment, you're working with trying to differentiate cells to specific cell types in the heart. But you're also doing something incredible. And we talked about pig transplants and why there are issues. And, you know, Tom spoke about it's replacing one disease with another. But you're also doing something with engineers that maybe one day will provide hope for entire artificial organ transplantation made of real cells, maybe the person's own cells. So, you know, briefly tell us about that and what's going on there.
So I've told you that we've been making human heart cells, and now we know how to make different types of human heart cells, the atrial cells, the upper chamber of the heart, the ventricular cells, the lower chamber heart, the pacemaker cells. And we also know how to make actually heart cells that are not cardiomyocytes, such as fibroblasts, different supporting cells of the heart. So now we can make all the like Lego parts of the heart. we know how to make all the different heart cell types. The question, can you put them together and build something that will resemble a heart? So there we're going more and more in what we call tissue engineering. And the idea is that your organs are not made only from cells, but cells that are growing on top of a scaffold from what we call extracellular matrix. So tissue engineering tries to use polymers together with cells to make tissue or even organs. So we've been, over the last few years, we've been mixing these polymers with cells, and we're able to make 3D tissues, heart tissues. The next level is what we're working now, is to use 3D printing capabilities and to actually print maybe organs or organ-like structures. And very recently, for example, we've been able to take a CT scan of a patient, generate his own atrial cells, and then use the anatomy of the patient and the atrial cells that we generate to print although miniaturized human atria resembling that patient. So we have in the lab now an entire atria of a specific patient that we can study why he developed atrial fibrillation and so on. But maybe in the future we'll be able to print, entire hearts. This is a lot of obstacles. It may take many years, but we will get the ability not only to produce the patient cells, but also to generate the appropriate anatomy and entire organ potentially.
So you take a cell from me. I mean, this is the future we're talking about. It makes all of the movies about the future seem pretty tame, if you ask me. So we take a human cell that we've got, we turn it into a pluripotent cell, we go and specialize it to the various types of cells we need in order for cardiac tissue of various sorts. We then print it together with maybe polymers in a 3D printer, and all of my heart problems are solved and I'm going to live forever. So, and that sounds pretty attractive to me. I suspect this is not going to be happening next week though, right?
Yeah, so there are a lot of challenges. One is, for example, the vascularization, because
so that means getting blood flow to what you're actually producing.
Yeah, because the muscle that you'll build, if it doesn't get oxygen, will die. So you're very limited currently in the thickness of the muscle that you can make. But the future, you will be able also to print, the blood vessels from the small capillary to the large coronary artery, and actually perfuse the organ that you're building. So you'll be able to generate these, very thick muscle constructs. Like I said, a lot of obstacles, maybe not today, maybe not in the next 10 years, but the technology is continuously developing, and we'll see where it goes.
So my challenge now is to stay alive long enough for your printed heart to replace my sickly old heart at some point down the line. Tom, let me, we've got 4 or 5 minutes left. And before I ask you a closing question, let me ask you a question from someone in the audience. So you're obviously very involved in diagnostic developments, and a lot of that is around prevention. But how do you think we strike the balance with a limited pool of money between investing in diagnosis and prevention and investing in treatment? And you're obviously very senior in the profession. You must have given this some thought. How do you think about this?
Yeah, I think this is the $64 million question, isn't it? That I'm in awe of what science can offer us here in terms of treatment, but fundamentally, we're going to be limited by what we can afford. And I think that it makes a lot of sense to put more effort into prevention. Some of that is behavioral, some of it is educational. So my personal bias, and I see both sides of the coin, is that we probably at the moment are not investing enough into prevention at the moment. I think that there is a kind of a public policy belief almost that heart disease is self-inflicted, when in fact it's not. Many heart diseases are genetic in origin, or at least familial in origin, as well as environmental. And I think we need to make better inroads into prevention. There's no question that the new treatments are going to be life-saving to some people, and hopefully many people. But at the same time, we mustn't neglect the notion of stopping people getting into extremis. And I think we could do a lot more.
Well, I mean, heart disease is self-inflicted only in the sense that you've managed to avoid dying of anything else in the meantime. So, I mean, it's the inevitable route for everybody who lives long enough is that they're going to develop heart disease.
Indeed.
And so I want to ask a question to each of you. I always like to end on a note of hope, although, you know, this entire conversation has been, frankly, the most hopeful conversation I've been part of, you know, with this Rambam series. But I want to finish on a particularly hopeful note, and I'll start with you, Lior, and then go to you, Tom. What is your biggest hope for an advancement in 10 years' time? In 10 years' time, what do you hope will be different in the treatment of heart disease than exists today?
So I think, first of all, Thomas, I think, touched the most important point is that in order to, you know, deal with a problem, maybe prevent it from happening. So prevention is probably the most important thing we do as doctors. And I agree with him that there's not enough of incentive, especially from the industry, to go into prevention. So prevention is a top priority. The second thing that I think what I noticed change over the years with cardiology, that we've become better in reducing mortality, especially acute mortality from heart disease. So now we've become, in a way, more of a discipline dealing with chronic disease. So now we have this huge number of patients that, you know, survive the heart attack and develop heart failure. So we have a lot of chronic diseases. And one of the things, personally, because of, you know, a lot of my aspects, because of my 2 decades of research, I would really like to see kind of a biological replacement therapy entering clinics in a useful manner, in an effective manner. I waited 2 decades for this. Let's see, since we started this stem cell research, I'm really hoping that in the next decades, we'll start to see actual clinical therapies coming out of it. There's very hopeful studies in other disciplines, whether it is macular degeneration in the eye that have seen promising results, diabetes, and so on. So hopefully I'll hope to see some kind of biological therapies and entering cardiology in the next decade.
So we're 2/3 of the way to your dream of therapies. That's good to know. I'm very encouraged by that. And Tom, what are your thoughts?
In 10 years, I would like to see a change in how we predict heart disease. I would like to see a process where children or young people are given are assessed on a polygenic risk score to understand their level of risk, and that some disease management program is undertaken in those people in order to stop them getting into deep water. At the moment, our efforts are too late, and a lot of the diseases that Lior and I struggle with every day are a consequence of that. So I would like to see the diagnostic strategy change for the prediction of heart disease.
Well, I mean, you know, it's been an absolute, I've really enjoyed this. It's been an absolute pleasure. I'm sure the audience has enjoyed it. I hope you've enjoyed it. And, you know, I think that it was tremendously insightful for everybody involved. And I really want to thank both of you for making the time. It was wonderful. And Vered, I'm going to hand back over to you.
Thank you so much, dear. Thank you everyone for joining. Thank you, Dr. Radir Schiffman, Professor Thomas Marwick, Professor Lior Gepstein. Thank you for all our partners, the Israeli Embassy in Australia, Zionism Victoria, Maccabi Victoria Cycling Club, and the President John Gould, Shlomo Immerman Partners, Gary Pierce, Zara Dilstein Jewelry, Pista Bike, Baker Hut, and the Diabetes Institute, and to Rambam Health Care Campus. Now, our next webinar will be on the topic of anxiety. Now, this webinar is a pre-event to Rambam Ride, which is going to held next week on the 27th at 7:30 in the morning. For the 4th year in a row, Maccabi Cycling Victoria and Australian Friends of Rambam have joined forces to improve community health and raise awareness of sudden heart failure. Now, the money raised for this event goes towards ongoing heart health awareness activities. Now, to end, please watch a greeting from Alistair McKellar, which is a professional Australian cyclist in Israel at the moment. So let me just share it.
Hi, my name's Alistair McKellar and I'm a cyclist for Israel Premier Tech. I'm originally from the Sunshine Coast, Queensland, but I now live in Girona in Spain. As a cyclist, I know how healthy cycling is for my mental health and for those around me. And that's when it comes to a big issue in our society, especially in Australia, which is cardiac arrest. Australian friends from Rambam. Join the charity ride Cycling from the Heart. Shalom.
Thank you, everyone, and have a good night.
Good night.